Hi, I'm Stephen Duckett. I'm the Director of the Health Program of the Grattan Institute, and welcome you all to this seminar, a State of Affairs seminar, webinar put on in conjunction with the State Library of Queensland. And I will just now share my screen, oops, to, sorry about that. To introduce the seminar. So with me today is Merle. So I'm coming to you today from the unceded lands of the Wurundjeri people of the Eastern Kulin Nations, and I pay my respects to elders past, present and emerging. With me today on the panel is Merle Mitchell, who's a former President of Australian Council of Social Service and a resident of Waverley Valley Aged Care Facility, which is on the unceded lands of the Woiwurrung people of the Boonwurrung people of the Kulin Nations, and also Mary Tetsos, who's Chair of the Board of the Aged Care Housing Group in South Australia and also Chair of the Federation of Ethnic Community Councils of Australia, who's speaking to us from Kaurna lands, the unceded lands of the Kaurna people. In Adelaide. So thank you all for joining us. What we're going to do today is I'm going to give a brief presentation which talks about some of the work that Grattan Institute has been doing in the area of aged care. We're going to be releasing a report actually this weekend on Sunday night, which has been done by Grattan staff, Attica Stobart and Hal Swearison from the health program at Grattan Institute. And this report follows up one we did last month, where we argued for a rights-based approach to aged care in this country. And what we're doing in this report is actually putting flesh on the bones. And just to recap, in our last report, we argued that the whole aged care system needs to be thrown up in the air and start again. That is, it is not an appropriately designed system. The Aged Care Act of 1997 is a sort of a Soviet-era style act which is based on a planning philosophy and a capping philosophy and a rationing philosophy. And what we should do is say, well, hang about, is that where we should be starting? Older Australians should have a right to aged care. We should have rights-based principles informing the aged care system, including that it should be about enabling independence and participation and supporting choice and control, not the so-called consumer-directed care, which assumes a market exists and assumes people have the information to make decisions and assumes there's transparency, but actually seriously thinking about what choice and control should involve. And that's what we argued in our previous report. As we move to our report that we're releasing this weekend, what we're saying is we need to base the new system on working with individuals to identify what they need, and that once we've identified what those individuals need, we should document that in an individual support plan, which essentially becomes a contract for their engagement with the system. And to the extent that this support plan includes what we call reasonable and necessary services, then they should be funded. And we say in particular that care costs should be taxpayer funded, but things that are typical living costs like meals and accommodation, that should basically be means tested. And that this would involve providing a lot more access to home care. We estimate we need to invest more than $4 billion to actually get the home care system one where people don't have to wait years to get home care. And the individual care plans would provide choice and control, that what we'd be on about would be the individuals that have an involvement in the system. What we're saying is the way this works is that a person needing care would have an assessment process undertaken by someone local, what we're calling a regional system manager, which would be accountable to a local board, not somehow waving off into Canberra or an aged care assessment service team. but basically a local regional system manager who'd provide assessment and support, who'd contract with providers to actually meet the support plan that has been negotiated with the individual, so it meets the individual's needs. So what we're saying is a universal entitlement, just like Medicare, just like the National Disability Insurance Scheme, for reasonable and necessary care. What we also say is that we should have portability. That is, that if a person is assessed as needing care, and if they would go into a nursing home, a residential aged care facility, and get this amount of money from government in the residential aged care facility, they should be able to get that same amount of money in the community. The home care should not be capped at a much lower than residential care, but if we could support people at home, we should be able to support people home if that is what they want to do. What we're also suggesting is that we need to have much better accountability, that the regional system managers would be responsible for care in their area, that the regional system managers will be responsible for healthy ageing programs to actually develop the market. No one's responsible for developing the market at the moment. That they would be accountable to the Australian Aged Care Commission. There'd be advisory processes so that people with lived experience both can be on the boards of the regional system manager and of the Aged Care Commission, but also providing advice as well, and that we should be able to have much better links between the agencies and the state governments and so on. So we're aiming for a local system, accountable locally and accountable nationally. So we're also saying that we've got to fix up the residential aged care sector. We've got to, there's been a number of studies which have looked at the quality of aged care, residential aged care. Story after story at the Royal Commission have told us things are wrong there. And so we think we need to actually start to have minimum staff ratios. We need to have 24-hour nursing supervision. So 20 years ago, residential aged care facilities were really very, very home-like, and the people in them were not as dependent as the people are now. The complexity of people in residential aged care has increased dramatically over the decades. And so now they look more like, the people in them look more like people who used to be in rehab wards or geriatric wards of hospitals 10, 20 years ago. And so what we need to do is say we need to put the nursing back in nursing homes. Basically, we need to have much more support in those in residential aged care facilities. And we need to actually make sure people have the right qualifications and so on. We need to actually make sure that people can have choice. That's better public reporting, better monitoring, better transparency. We need to make sure that if I get assessed near where I live, that the assessment process would lead to the same sort of result as if I get assessed near where Mary lives, for example, that there is equity right across the country. So this is not going to happen overnight. It's going to cost a lot of money. We estimate it will cost another $7 billion or so. This is we've been conservative in our estimate. That is, it's probably not going to cost any more than that. And so this is not something that can be done overnight. It's going to require a lot of extra staff. A lot of extra staff is a good thing nowadays when there's a whole lot of unemployment. And so you could see this as an economic stimulus for the good of old Australians and the good of all Australians through employment creation. But it will take a while to implement. There's a massive change that is needed. And we think it will take at least 3 years to roll out the system in a way which will implement a system like this into it, so that we actually address the problems that have been unearthed. And we think the problems that have been unearthed in the Royal Commission, in COVID and so on, is in part because we, all Australians, have not actually valued the contributions of older Australians. We said, out of sight, out of mind, and there's been a sort of an ageist attitude that we haven't been providing the support that needs to be provided. And so we want to actually see the implementation. We've suggested there should be an aged care transition authority to actually manage this transition, because it's a big transition and the existing structures haven't been working properly. So that's where we want to go, and that's where we think is the right direction. Next, I'm going to ask Merle to say a few words. Then I'm going to ask Mary to say a few words. and then we're going to open it up for questions. I've got some questions in advance that people were kind enough to provide to us, but I've also seen that people are commenting in the chat box. So if you want some questions, you can do that. So thank you very much for listening to me. And now over to you, Merle.
Thanks, Stephen. I'm really excited at the thought of having a rights system. That's been badly needed for a long, long time. I'm also excited to hear that you're saying more money, please. The solutions aren't just in more money, I'm sorry. It's all about the staff training. It's all about the recruitment of staff so that people who really want to be working in aged care really do want to be working in aged care. The thought of putting the nursing back into residential aged care is very important, I think, both from the perspective of the staff who are working where I am living, and I would think with most people. Staff are not trained to provide the sort of service that people in residential care, and I suspect too sometimes within home care, they just not got the training at the moment. And finally, as we were saying earlier, I think it's really important that we don't forget the need for interpreters who used to be provided in all services without cost. And now it's very, very hard for staff to even think of ringing and getting interpreter services for those who don't understand English.
Thank you. Thanks, Mel. Thank you very much for those comments. And I'll come back to one of those in a minute. So Mary, would you like to make some comments too?
Yeah, thank you. Look, I guess I just want to reflect a little bit on some of the aspects that you discussed, and I'll then go back to talk about a future state and how you've described that future state. One of the things you picked up quite well is the issue of rationalising services and our inputs into the system, and I think that aged care has suffered from that rationalisation as well as the need to contain. So in my view, that there is a waiting list for home care remains a national shame. No one should be at home needing care in order to stay home and wait, often so long that it's too late. So that is something that we should all be shameful of. I think the other thing that's been really interesting about the current system, and it's no one's fault, this is what happens when you describe the Aged Care Act as archaic. Well, this is what happens when you have a system and you bolt onto it. You keep on bolting onto it, never starting from a beginning to get first principles right, but corrections along the way. So much so that the system is clunky, that the system becomes unresponsive, that the system requires additional bolt-ons to navigate the system because you've made it so difficult. So once you have that as a public policy response to a sector, you end up where we are. So there is great merit in what you're suggesting, which is to start with a blanker canvas than we have ever done before. The alternative, which is to continue to massage and bolt, I fear will continue to create the problems that we've got. We've also got as a consequence of that a system that's quite perverse in its incentives, and unfortunately ACFI manifests itself in that way. So where you've got...
Sorry, ACFI, for those who don't understand, is the Aged Care Funding Instrument, which is the way you measure the needs of people in residential aged care, which determines the payment to residential aged care providers. Sorry.
That's right. So the funding instrument was intended to fund level of need. The unfortunate thing is that the more needy you are, the greater the level of funding, so that there is a perverse incentive in that funding model to keep people unwell, because you get more money for that person if they are unwell versus if they are getting better. So so the whole what you would consider to be a positive incentive, which is to re-enable people to make improvements, is actually mitigated by a funding system that makes people behave in the reverse. So what you have is essentially the setting up of a one-way street. So older people who can't stay at home who need more congregate care, and that's a legitimate thing to need. Sometimes your level of need is such that you actually can't provide it in a sole residence on your own. It becomes not functional. And there's nothing wrong with having an effective congregate care model, but where you create a perverseness in it, so that once you're in it, you never leave it. So the whole notion of being able to move in and out of residential care, where you can take your package with you, so that money that Stephen was describing at the level that is equal, whether you're regardless of the venue, and so that you could go into congregate care or resi care and you could actually be made better in order to go back home again, has to be built into this sort of new state. I think there's lots of questions about governance, which I've discussed with Stephen, and his report touches on those. The reality is that aged care is a private industry, and there are church-based providers, and there are not-for-profits, there are charitable providers, and there are small privately owned businesses that are family owned that provide residential care. There's new entities that are providing home care, kind of whatever the Uber home care, and there's publicly listed companies. This is a very diverse industry, and it's for that reason very complex to understand how to regulate it and how to govern it, because ultimately each one of these entities is responsible for its own governance. So while government is a heavy funder, so there's a lot of government money that goes into this, and by default, because it is so closely related to health and well-being, as we've discovered through COVID, must be regulated. The reality is that there are thousands of boards out there who actually own these businesses. They are not owned by government. So the risk profiles and the way in which they commercialise their business, the way in which they create charity in their business, the way in which they roll out workforce in those businesses, is actually the decision-making within the regulations of a whole bunch of individual boards. And that's often forgotten. It's as if they're sort of almost little hospitals, and they're not government run at all. I think the other thing that the report picks up quite well is the need to have connections across sectors. I mean, both Stephen and I have worked in health for a long time, and if COVID has taught us anything, it's taught us that we need to connect health and aged care and disability and everything else better together. It's also taught us that we can innovate if we are put in situations where we need to faster than we've ever done before. So that recognition of the importance to do things differently, COVID's shown us that we can do that. The good providers put consumers in the middle of their business, like at the centre of their business, and they offer that choice and control that Stephen and the report talks about. And in that, they recognise that a human rights model, which is that the older person has as much of a right to choose the way they live their life as I do. It's the how that's done that's the question. It's not the why or if. And I think the other really important thing here is that in order to have choice and control, and I'll speak here on behalf of consumers as a provider, consumers have to be really well informed. The problem with setting up a market model is that it assumes a rational consumer. It assumes that there's a person in the middle of this system that can make really well-informed decisions. that are based on rational choices, that are based on knowing everything that's available to them, that are based on understanding their own needs, and also based on understanding what they should be getting to get better. And that's not true. We don't have a rational, this marketplace of a rational consumer does not exist, I don't think anywhere, but particularly not in aged care. So when we talk about putting the consumer in the middle, from a provider perspective, my job is to make sure that if you are one of my consumers, if you're a consumer of ACH group services, that we need to make you a very competent decision maker, and include significant others in that process as well, which is family and other carers. Because while we keep consumers uninformed, they make really poor decisions, and we retain control. So you can say choice and control for consumers as long as you go, blue in the face. The reality, you can't. Is that you, Stephen?
Not me.
Oh, it's a bit of music in the background. All right. Well, I think that's it for me. I think that's me telling me that I've said enough.
That's said enough. Okay, thanks very much, Mary, for those comments. And I just want to pick up on some of the things that Merle said and some of the things Mary said before I hand it over to dealing with the questions in the chat, in the Q&A. Mary touched on the fact it's a complex industry, a large industry. And when we were doing our wandering around talking to stakeholders as we were writing these reports, they said, oh, you've got to worry about, if you do this, all of these aged care providers will be left with stranded assets. You can't get them to do this. You can't, as if the main thing we should have thought about in writing this report was the providers. Now, sure, we've got to worry about the transition. I think the transition is going to be a slow process anyway, and we've said at least 3 years, but the engine for change will mean it will take place over a longer period anyway. But what we said is, if we're going to write a report, we have to know where we're going to start. We have to know what our principles are and what we think the principles that ought to work in the aged care system are. So we needed to have a principle-based approach, and we said the way to do that, as Mary said, to put the older person in the centre, to have a rights-based approach. Because if you don't start from a rights-based approach, then you're going to have the wrong decisions. And Mary referred to the massaging of the existing Act and all of these sorts of things. It's not going to be possible to put a rights-based approach into the way the existing Act is written. It is just not going to be possible. So that's the first point. The second point is one of the things that Merle raised. She said, you've got to make sure that people working in aged care want to work in aged care. Absolutely right. People are, but we have to make it easy for people who want to work in aged care to work in aged care. We don't do that at the moment. We don't provide the appropriate training. We don't provide the appropriate career structure. We don't provide the appropriate money. And it is just unreasonable to say, you're a person who loves working in aged care, so you have chosen to be paid less than if you'd gone to work in a bank or on a plane or somewhere else. We've got to say, we as a society think it's really important that the people who work in aged care are paid appropriately. Fiona Smith, I noticed, has asked a question about the NDIS. I was horrified once a couple of years ago to go along to a seminar, a presentation by someone from the NDIA, the National Disability Insurance Agency, where they quite proudly said they were going to drive down the costs of paying for carers, attendants for people with disability. And they said, we're going to pay them X dollars per hour. And that's how we're going to structure the industry. And I realised that that X dollars per hour they were talking about is the same as we paid our cleaner. And that meant, and our cleaner, we communicated carefully because her first language was Mandarin Chinese and her English was appallingly bad. And so it's quite okay for a cleaner to be like that. She was a wonderful cleaner. But then I thought, does this mean that they're saying that the attendant carer, the people who are going to be attendant carers are going to have the same level of skill that our Chinese-speaking cleaner was going to have? To my shame, I didn't stand up and say, is this society we want? Is this what we really want? The principal thing that we want to do is to drive down the wages of the attendants. And that's the issue in aged care. We have not recognised the skill, the value, the importance of people providing services in aged care. We say in our report that at the very least everybody should have a certificate level 3, and that we actually have to make sure that when a vocational education provider signs off that these people have these competencies, they actually have these competencies, not some of the shonky things that's been happening in the past. So I'll stop there. And what I should have said right at the start was that to declare an interest that I sit on the board of an organisation, the Brotherhood of St Lawrence, which is an aged care provider. We provide both residential care and home care. So I'll stop there. And I'll return also to the question that Fiona raised. What, you know, do we think there's anything that needs to be changed in the NDIS? Do we think the NDIS is perfect? I forget where I can't see your question again at the moment, Fiona. But look, there are lots of things that are right about the NDIS model, and lots of things which need to change a lot. And we want to make the decisions local in the regional system manager, not everything being referred to Geelong to the NDIA. So there's a lot of things we've copied. The individual care plan, support plan model, you can see that copying, but we do want to change a lot. Now, there's been a few questions here about privatisation and private providers, and the fact that the public providers here in Victoria during COVID went very well, and the private providers didn't necessarily, including not-for-profit providers. Mary or Merle, do you want to comment about whether you think it is possible for private providers to provide good care, or whether you think it should be entirely government or not-for-profits and so on? So, Merle.
Stephen, I think there are for-profit services that are doing a good job. Mainly that's being driven by the managers that are put into place, who actually have very much a rights perspective. And that's from personal experience that I can say that the manager here has extensive experience and is determined that everybody here will get a good service. And I'm sure that we're not the only ones. So I think it's very easy to put people into little boxes and say, private providers don't do it, but the state providers do. I think that there needs to be, as you say, a system of actually judging the sorts of services that people are being provided with.
Thanks.
Look, I agree. I think it's site managers and the executive of an organisation are critical in terms of how well it works, as is organisational culture, which is what Merle's referring to. You know, how does the organisation operate? Who does it put first? And you can get really good providers. I mean, Victoria is unique because it does have a substantial number of public providers or government-owned entities that are government-owned facilities. It's not so across the country. So in other states, we've had really good performance of not-for-profits and for-profit organisations. So I think the important thing is to escalate and improve overall performance across the board and allow consumers choice about where they want to be, so that they can choose which entity type they would like to work with. And I think going back to a fully owned government system, well, I think is unrealistic. I think is unrealistic and unlikely. So we've got to focus on improving the range rather than going back to a model which is publicly owned. the capital requirements alone would make it prohibitive.
There's someone has asked, what are some of the key ways that people from culturally and linguistically diverse communities can be catered for in aged care to ensure that care is cognizant of culture?
Oh, Stephen, I've been. Mary, you can do it if you like.
No, please, you speak first. Absolutely.
I'm just thinking that I've been around for too long. When I was working in the community sector, we could just pick up the phone and say, I need an interpreter in X language. And that happened right across the board, whether you were working in health, in aged care, or in the community. And suddenly the telephone interpreter service disappeared and the limits were placed on the interpreters that you should get. I think interpreting in your own language is an absolute right that must be built into the system.
Someone on the chat box said, you know, language rights are human rights, or words to that effect.
That's
just
right.
Nicely phrased, I thought.
Yeah. Yep.
Language rights are human rights. Yeah.
I'm really pleased that for once, almost for the only time I can recall, it's not me having to say this, which is great. So yes, look, language rights are absolutely critical. I think we need to recognise that CALD people are consumers and also our workforce, especially at the bottom end of our workforce, or the caring end of our workforce. So the bottom end is the caring end. So it's really important. I think that there's ethno-specific organisations have done reasonably well during COVID. I know we had the incidents in Melbourne of a specific problem, which should not be a reflection on the others, and was triggered by circumstances that were specific to that location. But ethno-specific is not the solution. We can't have what we need, given the numbers coming through in terms of CALD, you know, in every suburb, in every locality. So it's the responsibility of all providers to make sure that they provide a service that is meets the need of the person that they're caring for, and work with that person to deliver what they need. And language is the most important thing. I mean, for 30 years, which reveals my age, 30 years I've been banging on about interpreters and language, and I still don't feel heard except for today, which is good.
Thanks. One of the questions that was asked in advance was about how do we ensure that these ideas just don't go into the dustbin? You know, there was a report from the Royal Commission which said, you know, there's been 20 reports in the last 20 years sort of thing. And how do we, you know, is the Royal Commission just going to be another dustbin report? Any thoughts on that, either Merle or Mary?
Yes, Stephen, I've been promoting with all my friends and contacts. They actually absolutely must express to government their support for the recommendations that have been included in the Commission's reports. They're very extensive. After a lot of money has gone into the work of the commissions, and we just have to make sure that government realises that the community wants these recommendations implemented.
Mary.
I think this has gained so much momentum. It is almost impossible for government to not take responsibility and move the Commission's recommendations forward. I think we have our own role to play, both as providers and consumers, to make sure that we maintain the pressure. I think we have to also make sure that we communicate these reports, that your report today that you will launch to the Minister as well, and of course send it off to the Commissioners, and ask government how it intends to implement, and hold them to account. And that's the only way forward. I think that there is enough momentum from both sides, because, I mean, if I can say that, I honestly think providers are looking for a way forward as much as consumers are. I don't think there's going to be resistance. You know, there may be somebody, but I can't think who, would resist the need for change. You know, this is a system that doesn't serve either anyone in some ways. Providers are really struggling at the moment because of funding levels and a whole bunch of things. So, and that's, I'm not crying poor. That's not the point of this. What I'm saying is that I think if we partner across and jointly try to move forward, we'll get somewhere. Because I can't see which stakeholder of all of them isn't going to want the change.
So thanks. I'm not as hopeful. If I think back to how we got the NDIS, that came from struggle. That came from community struggle. First of all, we had a Productivity Commission report, and the community, the disability community, led a campaign which led to a widespread Australian, everybody was involved and committed. And so the government was forced to respond. Now, there's been a lot of backsliding since then. But, you know, there was a campaign. Now, we could argue that the stories that have come out from the Royal Commission just make it so embarrassing not to do anything. But, you know, I still think we need to have pressure to make sure, to hold government's feet to the fire, and the opposition, but what are they saying as well? But we've got to actually hold the feet to the fire and do so publicly. And hopefully our reports here from Grattan will help in that regard. But I just don't think we can sit back on our laurels and say, oh no, the Royal Commission's done all the work that's going to happen. No, but I think you're right, Mary. I think that the providers also recognise that things have to change. But
I agree. Sitting back and is not my cup of tea either. I'm not suggesting. I think there's some momentum already there, and I think there will be a need to push that through. You're right.
Now, there's a question here which says, we do not need more nursing in nursing homes. That perpetuates the medical model of care. We need a new imagining of the role of a nurse and care staff in a rights-based environment. There needs to be a shift from the medical model of health and care to the social model of health. This is not to demean or see as vital the medical care and attention. Where do you see training for aged care, home and residential staff? So I'll start with that one. So what we're saying is that all the care staff should at least be Certificate 3 in personal care, that should also include training in rights-based care, rights-based support, because it is too easy for any carer, including a nurse or a personal care attendant, to actually do something for the resident, for example, rather than empower the resident, for example. So it's very easy, out of the goodness of the carer's heart, to say, look, it's time for you to get up, don't stay in bed, you need to go and have breakfast right now. And the resident might say, well, I've thought about it and I just want to stay in bed a little bit longer, thank you very much. And, you know, this fine line between accepting the resident's views and working with the resident. So, you know, yes, I agree with you. You've got to be really, really careful that if you talk about nurses, you'll end up the risk of the medical model. But we also have to acknowledge that a lot of people in residential aged care are quite dependent and quite physically, clinically dependent. And so we do need to have, I think, more nurses around. Now, what we've said in our report is there needs to be 24-hour nurses on site, and there needs to be ratios to actually make sure there are enough staff. We haven't said they all have to be nurses at all. That's not our view. And we have said that there has to be specific training in rights-based approaches. I won't say to untrain everything they learn, but actually to make sure that the rights-based approach, the independence approach, the social model approach that you talk about is actually what we actually do.
So I might just jump in and then Mel can have a go and correct us. Mel, you can correct us both. So look, from my perspective, it's always a case that we overcorrect. So we go from a medical model supposedly to a social model back to a medical. That's not the point. The point here is, from my perspective, is that you create opportunities for different models of care to come through and to meet the variety of needs that people have. And it's a spectrum or a kind of a sliding scale, or it's a range of needs. The truth of it is that in residential care, the length of stay is decreasing. So people are in there for between 12 to 18 months, and there is a fair bit of palliation that's going on in those residential facilities. And arguably that is fine. And in those situations, there will be more need to care for people as their acuity heightens. The reality is that the reason we're in this position where we have this sort of, binary thinking is that we don't think about alternative congregate care models, which are different from our current residential models where people are requiring palliation, but where people are coexisting and require a social support or a different type of support because they don't want to, that the social isolation of living in your own home is too much of a burden. So so instead of having binaries of home resi, we have a continuum where you can actually have a form of congregate living which supports people to no longer live in isolation, not in a pretend retirement village, but in a variety of models that provide people social and health supports as they see fit so that they can live well. So for me, it's not about ratios only. It's about providing a continuum so that older people can choose the point at which they're at, go up and down the continuum and get to the right place as their needs change. And if we invest properly in home care and funding models that allow people to take the money with them as they place themselves along the continuum, then whatever model it is will be determined by where you place yourself. And home care, investment in home care will alleviate the concerns we have about residential because people will be able to stay in home for longer. So that's a very complex way of answering that question, but it is requiring a complex response back.
Thanks, Mary. There's an interesting question here. Disability services moved from a responsibility framework to a rights-based framework over the period 1980 to 2020. It took 40 years to transition. I might add that when I worked in the Health Department of Victoria, I participated in normalisation training for this thing called passing, Wolfenberger's stuff on normalisation goals and so on. And that was in the 80s. So aged care is a responsibility framework that is just starting the journey to a rights-based framework. A transition will take at a minimum of 5 to 10 years. Question, what does the panel envisage as the key strategic imperatives or initiatives to develop, drive and deliver this transition in a timely, prioritised and practical manner? We've said in our report 3 years, blah, but we don't really mean that because the cultural change will take much longer. The cultural change to get the community to accept a different way of thinking about things, to get providers to transition is going to take a lot of time, as you point out. And as said, the disability movement took 40 years. Any comments from you, Merle? Or you might have been president of the Australian Council of Social Service at that time, Merle.
Yes. There were many experiences that we had where we were calling for change, but we did not say it was going to cost money. And that's where your report is so good, Stephen, because you're saying it will cost. I don't think that we at ACOS always, or at VCOS before that, actually recognised the costs that would occur because of the changes that we were demanding. And I think that the community too needs to understand that it will cost money. And if you follow the debates in the media now, people are saying we are prepared to pay. We don't mind paying our taxes if we know that people are being cared for, that we've got good education, good health systems, and good aged services. And I think we need to actually make it clear that we are understanding that it will cost, but we are prepared to pay for it.
Thanks. There has been a Sorry, I left my phone on. You're absolutely right, Merle. It's going to cost money, and we should be upfront about that. And there's been a survey by the Royal Commission, or a report from the Royal Commission, which said the Australian public asked, and they said, yeah, we reckon we need to pay more to look after Granny. That's
right.
Pretty clear.
Yeah.
I think the Productivity Commission made a mistake in I think it is true what they argued, that if you do the right thing about disability, more people with disabilities will go into the workforce. That will increase gross domestic product, and it will pay for itself over time. But that led to the impression that it wasn't going to cost as much money as it actually is. And I think we should have been much more upfront. There is a hump funding that was required in disability because, again, it was underfunded, just like aged care was underfunded. And we should have been a bit more upfront about all of that in that process of transition. But I think we have to be upfront that it's going to cost money, and the public are prepared to pay for it.
That's right. Yep.
So there's a couple of late comments there. Should we have a hypothecated tax, just such as the Medicare levy and so on? Our position, we decided we weren't going to get into how to pay. Because there's a retirements income review, there's all of these other things that are there's going to be an intergenerational report done next year. All of these things are going around in the environment. Grattan Institute has published lots on taxation and other sources of funding. We decided not to get into how to pay and just say, look, you've got to accept there's a problem that needs to be addressed. One way is an aged care levy. I think people will be prepared to pay for that. So I think that's where we should go on those sorts of things. I think, let me see if some of the other questions. Someone asked about federal-state relations. I could talk to you at length. I've got a joke about federal-state relations I could tell you if we had time, and I can talk about that at length. I think we've got a settlement that the Commonwealth is responsible for aged care, and they've got income taxing powers. So that, my view is, that's where we start. I don't think I want to start by redesigning the federation, but yeah.
I think if I could just jump in, Stephen, while you're reading the questions. I think one of the interesting aspects of state and Commonwealth relations has been during COVID, the issuing of state directives in terms of health and how they impact on Commonwealth funded entities. I mean, I don't want to go into it right now, but there's definitely conversation to be had there.
If you read the Newmarch report, if for people listening, there was this outbreak in a nursing home, a residential aged care facility in Sydney called Newmarch. And you read this report and you just weep for the residents and for the managers. Everybody under the sun was ringing them up daily to say, oh, do this, do this, do this. And they'd be on the teleconference. No one would tell the managers who they were and which agents they were. And the managers had no idea who was in charge. And the aged care quality people came in and the state public health people came in and said, you've got to send all your staff home. It was just a management nightmare because no one knew who was responsible for what. And, it is an area where we do need to tidy things up a bit. One of the interesting questions there is what we see as the role for technology in the future. How do we see technology changing any of this? Any comments from you, Mary, on that one? It really is going to change. It's changing healthcare a lot. I mean, during the pandemic, we ended up with telehealth. I mean, all of us spent days and every day in front of a Zoom, in front of a camera, and made these sorts of events possible. And the pivot to telehealth was fantastic. And I think there's been announcements today about embedding this into the future. But similarly, hospital in the home was really important, the development of virtual hospitals. Similarly, the home monitoring became so much more possible. And so our funding systems haven't really built in being, you know, the possibilities of using telemonitoring to actually, you know, make some assessments. And we can now have telemonitoring which tells you whether someone has got out of bed in the morning, so you can know whether how mobile they are and so on, and whether they've taken all their medication and all those sorts of things. So the potential, I'm an enthusiast about this. We haven't always implemented these things very well in the past, but I'm an enthusiast about what the potentials are. But I don't think we've got our funding arrangements right yet. If anybody
Stephen, I think you're right. I think it's been amazing how much help people have been able to get over the coronavirus through using technology. However, the one thing that does frighten me is that we might say it's so easy now to do it through technology. We actually don't need that human interaction. And I think that we have to balance what's happening and make sure we're not dependent only on using the technology. The human touch is really important in all of this, I think.
Absolutely, and it's so easy to say, oh, it's all going to be fixed by technology. I don't believe that at all. But we want to. That's why, amongst other things, we said you've got to have carers, enough carers to actually provide the care. And that's one of the things that we've seen with austerity generally across the world, that austerity has squeezed out the ability of staff to actually have the time to just sit around and chat and assess and so on. So it really is important.
Sorry, Mary.
I was just going to say, look, I think the role of IT has been fascinating, and it's part of that conversation I had about innovation and the way in which we've used different methods to do this, to make up for what we couldn't do. I know at ACH Group, one of the things that was lovely was there's a lot of the staff who felt that they had a spare iPad, actually brought iPads in to facilitate Skyping and a whole bunch of stuff with residents, and a lot of the younger staff running tutorials on how to use technology for older people, so they sort of become familiar. That process of human connectivity using the machine as the method of transacting was quite interesting. The other thing, of course, for providers is the recognition of the importance from our perspective to invest in IT back of house. So where you needed to, your surge workforce and your capacity to bring the right people in, make sure that people, had shifts that made sense and that you kept your workforce as stable as possible, and you were able to make sure that workers worked in infection control patterns, including one site per worker. Rostering and a whole bunch of back of house IT, I think, is now a priority. So obviously, I think IT is the interface between the consumer and IT, and what possibilities there are is really interesting. And as well as the back of house. At ACH, we've developed something also called the empathy suit, which we partner with universities, and young nurses and young carers put on a suit that is able to mimic what it feels like if you have Parkinson's. So you wear this thing and it actually weighs you down and it slows down your movement and makes you control your body in a way that someone that has Parkinson's or advanced Alzheimer's or physical ailment. And you wear that for a little while so that you actually can understand what it feels like to be in a body that is responding differently from the body of a young person. So so there's a whole way in which we can teach young people not just the knowledge of care, but the empathy required to do that care. Yeah,
when I was at La Trobe University, in the first couple of weeks of each semester of the first couple of weeks of the year, the students, I think doing orthoptics, had to put blindfolds on and have someone else lead them around the campus just so they'd understand what a very different experience it was. Someone here has said, no one has mentioned the personal care provided by family or the value it adds. These carers are not recognised. They don't get any training and are often required to leave full-time employment to undertake the care. Where will they fit into your proposed changes? So if I just might start by, I didn't talk about this, but one of my mental models is an onion model of primary care. People say, oh, the GP should be the centre of primary care. Well, that's not my view. The person with a chronic illness, or the person should be the centre. Around that person is their family and their carers, and around them are the home carers and the personal support, and then it's only the GP, and then it's the specialist, and then it's this. So yes, we've got to actually be putting a lot of energy into supporting the family and the carers at home, and that's what the individual support plan should be doing. They should be recognising that and actually saying, what do we need to do to make life easier for them? Because caring, as much as we love the person we are caring about, can drain us, and we need support ourselves to actually step out and then step back again. And so it is so important, and I agree with you, Sandra, that we should have talked a bit more about that, and we haven't, unfortunately. But Merle or Mary, do you want to say something on that?
I've seen so many people who are just exhausted by looking after people at home, and there is a tendency now to send people straight home from hospital because, oh, well, they're going to live with their daughter or their son and they'll be looked after. We don't need to worry about them. But what happens is that the person who's doing the caring at home actually becomes ill themselves and becomes absolutely exhausted with the work that they have to do.
Yeah. Sorry,
Steve,
Mary.
I was just going to say, look, from I guess this is my personal view and one that I'm exploring. I absolutely recognise the role of family carers and family and friends and informal care networks. I think that the difficulty here is that society is changing, and it's not a difficulty, it's the reality, and we're one we've wanted for a long time, where we want a really engaged workforce, which includes women entering that workforce and being able to stay in that workforce. And especially for CALD communities, there's this almost portrayal of this extended family that's happily wanting to give up everything they do in order to care for their older person because it's culturally what they do. I can't tell you how mythical some of these things are. I mean, the mythical woman who wants to stay at home and do nothing but care for children and then older people simply increasingly doesn't exist. Not because they don't love and care for the person, but that they have a range of responsibilities and have now finished their own studies and are in careers which we encourage them to be in. So I recognise the informal networks. I'm simply saying we cannot rely on them, and it's not unfair to do so.
And we shouldn't have an expectation, as this society has had for a long time, that the daughter is going to be the carer and they're prepared to give up everything and blah, blah, blah. It's
I'll be effeminate. Look, I think we've done a fine job destroying the prospects of women for many centuries. I don't know why we can't be a bit cleverer and stop doing it.
Yeah. Anyway, so we've only got 1 or 2 minutes left. I'd like you to, people who haven't looked at the question and answers, the chats, you'll find lots of links that people have put in there. As you know, this is jointly sponsored but with State Library of Queensland as part of the State of Affairs series, and there's some links there to more resources and so on. There's other links people have put to IT reports and all sorts of things that are really, so if you're interested, have a quick look through the Q&A before we sign off. As I said at the beginning, the Grattan report is going to be issued on this weekend. A lot of what we've talked about is covered in there, and it will be available on the Grattan website, grattan.edu.au, on Sunday night, Monday, and so on. We've got 30 seconds or so left. Any final words of wisdom, Merle?
I just want to say this is our best chance that we've had in years. Please let government know that we want change and we support change, and we don't care what it costs.
And I have nothing more to add. That's a great way of finishing. Mary, anything from you?
I'm happy to. Well done. Well said, Mel.
Well said, Mel. So thank you, everybody. Thanks, everybody, for coming along and listening to us and asking those great questions. Thanks very much. Bye-bye.
Thanks, Stephen.